I was just going to say, I don't want to steal any of Anne's thunder because I heard her presentation the last time, so I'm not going to give away too much. But I will say that when Anne presented at the retreat her project and the way that the project was conducted, it kind of resonated kind of with the type of practice we have. We have a group of clinicians that try to go after an underserved group that have really challenged access to services. And we kind of assume we know what those people want, but perhaps there is a better way we can do to figure out what the patients need and how we can best provide them that care. And so I thought it kind of mirrored maybe what's going on in Africa a little bit in Côte des Neiges, and seeing how some of the lessons that Anne has learned of how to conduct this type of research could also be applied locally as well and inform us into how best to provide services.
That's great. And then at the very end of the presentation, before we move to general discussion, I've actually asked Dr. Milan Graziani from St. Mary's Family Medicine Group. So she's also going to give her perceptions as a clinician, what she heard about the presentation before we open it for general discussion. So thank you very much, Mark, for that appetizer. It really does whet the appetite. And over to you, Anne. It's all yours.
Thanks very much. Thanks, Mark. You didn't. There were no spoilers. So, okay. So I'm going to. I believe I can share my screen.
We don't see anything yet. Oh, here we go. We see it.
Excellent. Can you still see it? Okay, good. Perfect. So, good afternoon, everyone. Well, good evening from Botswana, where I'm joining you from Botswana today. It's a great pleasure to have this opportunity to present some work we're doing with adolescents in northern Nigeria, and to discuss how it might potentially be relevant to family medicine practice in Montreal. So the work I'm going to present today is part of a long-term research partnership in Bauchi State in northern Nigeria. So CIAT, which is a research and training NGO, has been working with the Bauchi NGO, the Federation of Muslim Women's Associations in Nigeria, or FOMWAN, and with the Bauchi State Primary Healthcare Development Agency for about 15 years. CIAT joined PRAM, Participatory Research at McGill in the Department of Family Medicine about 10 years ago, and we've continued our partnership with Bauchi. So over the 15 years of our work in Bauchi, we've been supported by several different funding bodies. As you know, individual research grants are rarely for more than 5 years. So the research I'm going to be talking about today is part of a project funded by CIHR. Many people are involved in the work, and I've just listed a few of the key people here. So adolescents face many health risks, not least to their sexual and reproductive health. And of course, the pattern of risks varies from place to place, but there are many commonalities. Very often, services and interventions intended to improve adolescent health, including their sexual and reproductive health, they're planned and implemented with little or no input from adolescents themselves, especially not younger adolescents. This may be one reason why they're not always effective. So the challenge is how to engage adolescents meaningfully in documenting and measuring their concerns and problems, and in co-designing solutions, which would include services. So as part of our participatory research in Bauchi, we're trying to do this. So it's part of a 5-year multi-method project, which aims to answer several research questions. They focus on understanding factors affecting adolescent sexual and reproductive health, ASRH for short, and co-designing evidence-based actions to tackle the identified priorities. We're aiming to engage adolescents meaningfully across all of the questions. It's a large ongoing 5-year project with many aspects. In this presentation, I'm just going to focus mostly on how we're engaging adolescents and what's emerging from doing that. So this is just a very brief overview of the project. We used fuzzy cognitive mapping, which I'm going to explain just now, to document community views about good adolescent sexual reproductive health and the causes of good ASRH in the Bauchi context. We preceded the fuzzy cognitive mapping by some focus groups. And then guided by the priorities emerging from FCM and focus groups, we conducted a survey focusing on the identified key outcomes and on factors related. Right now, as we speak, we're co-creating materials to share the findings with community dialogue groups in 30 intervention communities. This is where we've got to in the project. Going forward, we're going to support adolescents to create and share cell films within their communities. The dialogue groups of adolescents and other stakeholders will discuss the evidence and co-design actions based on that. We're going to evaluate the impact of the intervention, the dialogic intervention, with a repeat survey in all 60 communities and through collecting narratives of change from participants. So to conduct focus groups with adolescents, we trained a junior team, as we call them, of 10 young women and men aged between about 17 and 23. So some of them are still adolescents and others are just post-adolescents. And they joined our existing Bauchi research team. They won't mind my saying that some of them are a little older than that now. We're all getting older. The younger team conducted focus group discussions with separate groups of adolescents, girls aged 10 to 14, boys aged 10 to 14, boys aged 15 to 19, and unmarried girls aged 15 to 19, and married girls aged 15 to 19. Many of the girls in Bauchi get married before the age of 19. So it's a total of 30 groups in 6 communities. The adolescents had a number of concerns about their health and well-being, and they went beyond what you would think of as narrowly health issues. They included gender violence, sexual abuse, early pregnancy and forced early marriage, general violence, drug use, mental health problems, and also more general issues that they related to their problems like poverty and unemployment. Of course, the experience of adolescence is strongly affected by their parents and communities. So we also conducted separate focus group discussions with parents of adolescents, with community and religious leaders, and with service providers. This was a total of 30 groups in 6 communities, and we looked at urban, rural, and rural remote communities. And we also convened some focus groups with service providers, planners, and policymakers at different levels of government, like at ward, local government authority, and state levels. The focus groups of adults and service providers, they had a slightly different take on things. They identified some of the same issues, but they focused on things like sexual misconduct of adolescents, poor morals of adolescents, mental health problems, drug abuse, and they talked about the adolescents getting involved in crime and thuggery. Our facilitators are very experienced, but despite their best efforts, many groups spoke about the problems caused by adolescents rather than the problems faced by adolescents. So there are a number of definitions available about what constitutes good ASRH, but they're mostly from high-income countries and of limited relevance in the Bauchi context. So in an iterative process, we consulted with adolescents and with other stakeholders to agree on a working definition of good ASRH in the Bauchi context. This working definition that emerged, it combines the views of different stakeholders, and it specifically includes the views of adolescents themselves. As a result of these consultations, we have an agreed list of the components of good ASRH in the Bauchi context. I'm not intending you to read what these are, these 6 elements. The image on the right is the Hauser version, by the way. We use this list in our next step, in which we ask adolescents and other stakeholders to map out their perceptions of the factors that can contribute to good ASRH in Bauchi. So we conducted fuzzy cognitive mapping with adolescents and with different adult groups in the communities of our project, in the same categories as for the focus groups. Altogether, we created 60 maps with adolescent groups and 60 with other adult stakeholders. There were more maps than focus groups because each group produced 2 maps, one of factors related to ASRH in girls and one of factors related to ASRH in boys. This thing, fuzzy cognitive mapping, or FCM, it's a way of displaying often complex causal links in a graphical format. We use it as a participatory technique to allow stakeholders to depict their perceptions about causes of an outcome and the links between these causes and each other and with the outcome. We've used FCM in many different settings and we found it pretty robust and flexible. It can work across different ages, different languages, different levels of literacy. In Bauchi, we were particularly interested to see how well it might work with young adolescents, aged 10 to 14. Would they be able to do it? So I promised Jeannie that I would say a little bit about this thing, fuzzy cognitive mapping. So a fuzzy cognitive map is a graph, basically, representing the factors related to an outcome, causally related to an outcome. In this case, the outcome is good ASRH, mapped separately for boys and girls. So the factors that the participants might link to good ASRH might include parental care, monitoring of adolescents, not having forced sex, and having good morals. These might all be seen as linked directly to good ASRH, but there might also be links between them and indirect routes to good ASRH. We usually, at the end of the mapping session, we usually ask participants to weight each link according to its strength. So with 5 for the strongest link and 1 for the weakest link. I'm going to share with you a set of pictures showing an FCM session so you can see the different steps. This is from a previous project in Bauchi, in fact. So for each mapping session, a facilitator leads the discussion and creates the map according to the instructions of the participants. A separate reporter takes careful notes during the session, and these notes clarify the meaning of the concepts on the map and the reasons for the links that the participants make and the weights they allocate to those links. This report is very important, as important as the map itself. So the facilitator first explains the process to the participants and gets their agreement to proceed. The facilitator then places the central outcome on the board. In this case, that I'm showing as an example, it was a map of factors related to kunika, or short birth interval. The participants give their ideas about causes as central outcome, and the facilitator writes them on labels and places these on the board. Now, you can use post-it notes on a big piece of paper for this. In Bauchi, we use magnetic tiles on a metal whiteboard, and we find it's quite a robust way of doing it. We find it helpful to make sure that everybody participates. We find it helpful to go round the group in turn several times until no more new ideas are forthcoming. Then the participants start to indicate links between the factors and each other, and between the factors and the central outcome. And the facilitator draws arrows to show the links proposed by the participants. And then the participants are asked to weight the strength of each link in turn. Here's another example of weighting the arrows. So this is an example of a fuzzy cognitive map of perceived causes of good ASRH for girls. This map was created by a group of unmarried adolescent girls aged 15 to 19. Often the maps depict certain factors as influencing many other factors in the network, like parental care in this map. Using social network analysis, such factors have a high out-degree centrality. Other factors may be important outcomes in themselves, influenced by many other factors, and we would say they have a high in-degree centrality. Not surprisingly, the central outcome here, good ASRH in girls, has many factors influencing it. But you can see that good character also appears here as an important intermediate outcome with a high in-degree centrality. At the end of each mapping session, the field team photographed the map as the permanent record of essentially the raw data. Ahead of further analysis, we digitize the maps. There are lots of packages to do this. We generally use YED. In some contexts, it's possible to draw a digital map directly, especially when you're working with an individual rather than a group. We conduct our mapping sessions generally with small groups. So I'm not today going to describe in any detail the analysis of fuzzy cognitive maps, but briefly, there are a few steps. Fuzzy transitive closure calculates the maximum influence of each factor or node on others, taking into account all direct and indirect influences on the map. To aid interpretation and communication about the maps, which are often quite complex, we group the individual factors into broader categories in a sort of thematic analysis. We create average category maps for the different groups of stakeholders. So, for example, we may have an average map for adolescents and another average map for adult stakeholders, or we may have an average map for females and another average map for males. As a further guide to communicating about the findings, we often create summary maps showing just the most important influences. In our work in Bauchi, we're engaging stakeholders in analysis, in FCM analysis. We're involving them particularly in the categorization of factors into broader categories. This is a process usually undertaken mainly by the researchers. So the participatory analysis of FCM, or collaborative categorization, as we sometimes refer to it, began with working with the Bauchi research team. They're all seasoned researchers and they're familiar with the factors because they've facilitated and reported the FCM sessions. So they found it quite easy to group the factors into broader categories. But we went further and we engaged community stakeholders, including adolescents, in this collaborative categorization. We developed practical ways of presenting the factors to the groups so they could physically group them on the boards. Even the younger adolescents managed well. I should say that for the younger groups, we only asked them to group factors that had appeared on maps of younger adolescents. So they weren't trying to group factors maybe they didn't know anything about. We believe that this participatory analysis will potentially produce categories more reflective of the local context than those produced by researchers who may have very different worldviews. So this shows an example of categories created by a community group. You can see that they've grouped the different factors on the board. So the focus groups and FCM guided the development of an instrument to collect quantitative data about the priority ASRH outcomes identified from the focus groups and FCM, and about the risk and resilience factors that they'd also identified. Young members of the Bauchi research team, the junior group as we call them, had a key role in developing the electronic questionnaire and in piloting and adjusting the questionnaire and the field processes for a baseline survey. They were really part of the group who did that, and there were substantial changes during the process. So we recently completed the survey in 60 communities. Some 8,000 adolescents aged 10 to 19 completed the questionnaire in interviews in their homes, 6,000 girls and 2,000 boys. And more than 3,000 parents or caregivers of adolescents also completed the questionnaire. Based on the preliminary analysis from the survey findings, we've prepared fact sheets of the key findings from the survey. And we're going to share the different kinds of evidence from the FCM and the survey in dialogue groups of adolescents and other stakeholders in 30 of the 60 communities. This is the intervention in our project. So preparation of materials for sharing the evidence with communities is another opportunity to engage with adolescents. In previous projects, we've found docudramas in the popular Nigerian soap opera style to be a good way to share findings and spark discussions about solutions, sharing the findings with community groups. In this project, we're co-creating these dramas with adolescents and other community stakeholders. So facilitators presented the facts on key topics to separate small groups of adolescents and adults in communities and asked their views about them. And they asked them to come up with storylines and dialogues, including doing role plays for including the findings in docudramas. The groups have suggested some wonderful scenarios to include in the docudramas, and the adolescents have been especially enthusiastic. The stories and dialogues in the docudramas will very much reflect the local context, and they all come from what these groups have suggested. So that's where we are up to now. One more way we're going to engage adolescents is by supporting them to prepare cell films about ASRH topics after they hear about the findings from the FCM and survey. So a cell film is a short 1 to 3 minutes video filmed on a cell phone to express experiences or views of the creator or creators of the cell film, usually about an agreed theme. We've already trained our junior core team to make cell films, and they're going to support adolescents in communities to do so. We propose that when adolescents create cell films and share them with more powerful stakeholders, this will allow their voices to be heard and should flatten power gradients for future joint meetings, which we're planning between adolescents and other stakeholders. So the cell film training is about to start, and we're very excited about it. So just some reflection on the engagement of adolescents. I think that so far, the engagement of adolescents in this project has been quite successful, and we're hopeful it will continue in the next phases. I think there are several reasons why it's working. Some of them are specific to the Bauchi. First, we've been working with communities and local partners in Bauchi for 15 years. This has built up relationships, partnerships, and trust over time. It was very important that we took community leaders, religious leaders, and parents into confidence about what we proposed to discuss with the adolescents, including the younger adolescents. So they felt comfortable about what was being discussed with the adolescents in their communities. As I mentioned, we recruited and trained a young local team to join our existing core research team and interact with the adolescents. It's really helped. It's been crucial. I think an important consideration is that we involved the adolescents from the beginning and as active partners, not simply as passive participants. They helped to define the parameters, what is included within good ASRH. Their views about the causes of good ASRH count. Their maps are equal with the maps of other stakeholders. And they're interpreting the findings and co-designing communication about these findings. And we're going to ensure that their voices are heard in dialogue groups tasked with co-designing solutions. We didn't make assumptions about what young adolescents would or would not be able to do in the research. We tried things out and made modifications as necessary to allow the youngsters to participate. Nor did we make assumptions about what they would want or what they need to help them to have good health. We listened. So just by way of rounding it up, we believe that the work in Nigeria could have relevance for practice in Montreal. The immigrant population in Montreal may have some ASRH challenges, not unlike those of adolescents in Bauchi. So some solutions in Bauchi may resonate in Montreal. But probably more importantly, the process of engaging stakeholders, including adolescents themselves, in understanding and depicting the issues and in co-designing solutions and services to support good ASRH could also be applied in Montreal. We hope that this has the potential to change the way that family physicians and other health workers provide health services tailored to the needs of adolescents in Montreal. So thank you very much, and hopefully this would lead to some discussion. Thank you.
Thank you so much, Anne. That was really wonderful. I really appreciate that. And I do encourage everybody, if you've got questions, there will be time for open questions, but you can also write things in the chat and we'll try to pass those on. But just before we move on, I'd like to give the word to Dr. Milan Graziani, who is a family physician and at the St. Mary's Family Medicine Group affiliated with the university, just about how she sees this related to practice, or what relevance she sees from Bauchi to Montreal and from research to practice. Go ahead, Milan.
Hi, it is, can you hear me?
Yes, we can.
Hi, I'm really sorry. I'm like getting out of the metro towards St. Mary's, but I'll have a few quick words. Thank you for having me. And this was a very interesting presentation. And I definitely think there are things we could apply, especially in the Côte des Neiges area. I'll just quickly talk about what we do at St. Mary's. So I'm guessing this is similar to the teenage health unit at the Herzl. We have a youth clinic that runs once a week. That's basically, yeah, pretty much for reproductive and sexual health in youth, like a population we don't see very often unless they come to us. So 14 to 25-year-olds, and it's there are appointments and there are walk-ins as well. And I have to say, we've had a lot of trouble with recruitment, and it's probably because we don't fully know how to reach this population. You know, we see a lot of them in our clinics, and they're often coming with their parents, and their parents are the ones who are taking their appointments for them. So I think there is something there where trying to get a little bit of their opinion and their ideas on what's important to them, and you know how we can reach out to them. That could be definitely interesting. Yeah, that's a little bit of the stuff I wanted to say about that. I don't know if you had anything you wanted me to discuss specifically.
So just reiterating that you are definitely seeing a relationship in the process as much as anything about how to better reach a population. Like you feel, even though there's this youth clinic, it feels like you're not really meeting the extent of the needs. Did I get that right?
Yeah, pretty much. I mean, I think we have this kind of way of thinking, know how to book patients, how to reach out to patients. That's a bit more tailored to the way we see our system, but these adolescents who don't always subscribe to the same schedule and routine that we do are a little bit more difficult to reach out to. And yeah, I think there could be some interesting thought process there on how to reach out to them and fulfill their needs a bit more.
And it's pretty difficult to see how this could be done in the context of clinical practice, which is where a relationship or a partnership with a research team would be really helpful.
Certainly. And you know, the goal of this clinic was also for like some academic needs as well, because you know we're forming the new family doctors and we're trying to expose them to this population that doesn't really come to us. I did see in the chat quickly that, you know, maybe something that's more outreach would be interesting. And, I think we'll keep it in mind if we see we're still not really fulfilling the needs.
Yeah, but I think that so much of our practice-based research even is focused on that model of people coming to the clinic rather than reaching out into the community and finding out what the needs are. Yeah.
Absolutely.
And did you have any comments on that you wanted to make?
Yeah, just to say, I didn't mention it here, but because I haven't mentioned the results of the survey, because that was there's lots and it's very exciting, but it's too much for here. But one of the things that was clear is that the adolescents in Bauchi are not using health services for adolescent sexual and reproductive health for lots of reasons, not least for sort of reasons of confidentiality and so on. And they go to great lengths, like go to a place somewhere in a different community with somebody who pretends to be their husband so they can get an implant for contraceptive care, because contraceptives are not available to unmarried adolescents. So there's some particular issues there, but definitely the same issue about adolescents not using the services. And we accompanied this with some institutional reviews of the health facilities, and they didn't have special arrangements for the adolescents. So we're starting to see just those same issues, that if the services could produce things which were more tailored to what the adolescents are asking about, then yeah. But of course the problem is if you survey the people who are at the clinic, even if there are some issues for them, clearly that the issues, they've managed to get over the issues because they've come. So it does sort of say, well, maybe you need to go beyond the ones who turn up. You need to try and reach those who don't go to the clinic.
Yeah, thank you. And there's some comments in the chat about even at the Herzl, most of the referrals come from schools, and that there's the CLSC nurses who go directly to the schools, that the schools become the main kind of like focus for clinics. And Catherine Haskins has made say to connect with Air Ouverte clinics. Can you just explain briefly what that is, Catherine?
Sure. Can you hear me okay?
Yep.
I don't know if my video is working or not on this iPad. Oh yeah, a little bit scary after the gym. Yeah, I work in the CLSC in Pointe Claire, and there's a couple of new ministerial projects called Air Ouverte. They're for adolescents and young adults who are not able to, for different reasons, they don't trust the regular system. They're immigrants, they're street youth, they're the most highly vulnerable youth. And they've got an integrated service with nursing, employment services, mental health resources, physician consultants, social workers, and so on. So the idea is you have all these different interconnected things. What do youth want? They need mental health, they need contraception, they need help navigating the welfare system, help looking for a job. So the idea is you bring all those services together in these groups called Air Ouverte. It's actually what the CLSA youth clinics were somewhat like 20 odd years ago. But anyway, there's two clinics in the West Island and in Dorval-la-Chine area, and there's probably, I'm not sure if there's one near Côte-de-Neige. So that's another hub area, and we're looking in the West Island at the mandate for the youth clinics, because school nurses do most of your sexual health now. They can prescribe birth control in the schools. They can test and treat chlamydia if it's not symptomatic. So a large part of that service is done by nurses. And I think if you really want to recruit vulnerable youth, you need to throw in mental health service with your service offer, because it's all part and parcel. A girl comes in for trouble with your period, but you pick up she's also depressed or anxious. Someone comes for substance use issues, but you realize they also need to think about STI screening. So they're all rolled in together. And I think that you need to look at very vulnerable youth if you're working with adolescents, because the school nurses can do a lot of the basic stuff now.
Yeah, thank you. Thank you, Catherine. Gracie, you have a question followed by Tibor?
Yes, hi, thank you, Anne. It's so nice to see what our colleagues are doing. Really interesting presentation, thank you. So I have a question about the process. I'll be venturing into a kind of participatory co-construction of an intervention soon. And I wondered if in that process of the collaboration, do you have advice for if among the participants there might be some adversarial positions sometimes, or perhaps some beliefs that, you know, may not necessarily concord with generally accepted science? And, you know, I expect to encounter this and I want to navigate it carefully. If you had some advice.
Yeah, it's very interesting that you raised that. Thanks, Tracy. I mean, it's quite visceral, actually. I mean, I've sat in on some of the groups where they were kind of categorizing factors from FCM and so on. I didn't agree with them. And then I thought to myself, well, actually, it doesn't really matter whether it's not your view that counts. And so it's a kind of a process. Researchers, when we're doing participatory research, we have to relinquish a certain amount of power. It's kind of uncomfortable, but it's also good. And then we also have to recognize that, you know, it depends on the context. Like in Bauchi, for example, a woman is pregnant and wants some pregnancy care. She has to get the permission from her husband. Now, you know, we may not, you know, that may not resonate with us, but it's not for us to say we're not going to change that overnight. So within that, what can be changed within that? So I think, yeah, it is an issue. And there's in the Bauchi context, there's for example a lot of homophobia, and that's where they're coming from. It doesn't mean that can't change over time, but it does mean that you need to be aware of that and, yeah, navigate it. And but you often find that some people in a group may express one view, and then you'll find others who say, well, no, it's not like that. But it's a question of allowing them to sort of make that shift, rather than you as the sort of, you know, the white coat making that shift. I don't know if that helps, but it's a process.
So important. Tibor had a question, and then followed by Abdul.
Yes, thank you. Thank you, Anne, for this presentation. It was very insightful. I have a question regarding the fuzzy cognitive mapping. So I'm very interested in that. As you know, we use similar graphs and causal inference per se. So they look the same, but the way we derive them is a bit different. But just in terms of the pragmatic aspect, how do you explain to participants this method? Which training, explanation does it take? I mean, I can imagine with different groups, you may have more efforts and less success maybe in really pitch the idea of what are you trying to achieve, right? So do you have any tools? Is there a standard procedure? How do you get them involved? I'm really curious, how do you do this in practical terms? What are your experiences?
Yeah, we're developing some sort of manuals about how to do this. Look, it's deceptively simple, but actually you really need to train your facilitators well, and you need to train your reporters well. In terms of people getting the idea of what they're to do, that's not that difficult. That bit is actually quite easy. When, you know, if people say, you know, so long as they understand this is the central concept, you know, and we want you to tell us what you think causes this. So it is about their perceptions of cause. Now, it may not be, we're not saying that's an actual cause, but we're saying this is their perceived cause. And people don't find that difficult. You do need to be careful that the facilitators don't have an effect on it, a facilitator effect, if you like, particularly when you're drawing the links. It's quite important that the facilitators allow those links to come from the participants. So that it's important to train the facilitators, and it's important to train the reporters, so that something that you think, what's that link about? But then if you look at the report from the group, you understand why they linked it in that way. It may not be why you would have linked it in that way, but it makes good sense to them. So yes, I think in terms of your question, is it hard for the participants to understand what you want them to do? No, my experience, it isn't hard. And even how do you do it with people who can't read and write? People who can't read and write have very good memories for where things are. Mm-hmm. So they very quickly learn, okay, the one that was over here is this thing. And it's people who have limited literacy do really well at this. Mm-hmm. Of course, the facilitator has to keep reminding them what's written on the tiles and so on. So it's quite robust across those sorts of issues.
Okay. And just a quick follow-up, I don't want to take too much time, and thank you. That's reassuring to hear that it's feasible. The tiles, are these already given, or are they also, they have to come up with the nodes in the graph? Like, are they just drawing the edges?
The tile, they're fridge magnets, basically. And they're just a plain, and then they write on it with a marker.
They write on it. So they they construct the whole thing. It's not just having already the tiles in place and then kind of...
No. They construct it from scratch.
They construct it from scratch. Okay. Thank you so much.
And one thing I would say, sorry, I don't want to take too much time either, but that, of course, one of the things you're going to do when you have to combine maps is if one says Western education and the other one says Western style education, then that's the same thing. So what we've found, particularly when we're doing lots of maps, is we have a sort of iterative list of concept labels, and then the facilitators have that, so that it helps with the later analysis that they word it in the same way.
Thank you, Anne.
Thank you. Abdul, from the same part of the world, I think. Your question?
I'm back to Canada. Thank you very much for the wonderful presentation. And I have so many questions, but I'll focus on just 3 and I'll be very quick. So from the work you've been doing, I know time and resources makes a huge difference. So supposing maybe I'm a PhD student who wants to do something with adolescents, but I don't have the resources and then don't have that much time. What specific approaches can I still take to build the trust needed? Because the trust is something that we really need before they can open up. And then my second question is on the issue of power, looking at the specific context in which you find yourself when dealing with adolescents.
Say that again.
I'm talking about the issue of power difference. That's the second question, power difference. When dealing with adolescents, bringing them in the same space with other stakeholders. Sometimes, like using my case as an example, I trained the adolescents prior to the deliberative dialogue, but you realize on the day of the event, the adults still dominate the procedure. So sometimes I don't think a single training or maybe double training session can make a huge difference. Expect them to come in, be so much empowered. What other approaches can we take to ensure that they are well empowered to be able to contribute to the level expect them to contribute? And my last question is, when there is conflicting recommendations from adolescents and then the other stakeholders, how do we address this? Thank you.
Thanks. They're good questions. I think you were saying you don't have 10 years to build trust. Well, that's true. But if you're fortunate and you do your PhD with a group that has that 10 years, then that can help. But also, Abdul, I believe you have good contacts where you're working. So I think you've probably already dealt with some of those issues. The power difference in dialogue. One of the reasons we're doing cell filming is that by sharing the cell films, which gives the viewpoint of the adolescents, sharing those first with the more powerful groups can help to, let them know without the adolescents having to front of them and say, this is what we think and believe. And there's some evidence for that these participatory visual media can help for that. Conflicting views, yes, well, we're not necessarily expecting to get agreement here. These dialogue groups are not necessarily, oh, we're all going to go in the same direction. So you don't have to come with we all agree to this. It's not like reaching a sort of a vote on it or whatever. So I think sometimes the conflicts are useful and can be discussed, and why is there this conflicting view and so on. So don't worry too much about conflicts. I think that's natural and perhaps sometimes useful.
Okay, sure. Thank you very much.
Thank you. Just before I give, I'd like to give the clinicians the last word about what they see as relevant. But just before I make that transition, Paula, perhaps I could get you to put your camera on if it's functioning. And I did want to just say that Paula is a resource in our population, in our department, who's done a lot of participatory research with organizations and actually has tools that she can help to offer any teams who are interested in these kind of participatory methods to help circumvent and preempt some of the issues that have been raised today. So thank you very much, Paula. I guess your camera isn't on because you must not be working, but please reach out to Paula. She's a wonderful resource to us. So I just, as we are sort of heading to a close, I just want to
trying to get my camera going.
Hi, Paula. Do you recognize her? Thank you so much, Paula. And maybe, I mean, I'm sure that if you could just pop your contact into this chat as well for everybody, we'd love to be able to reach out to you. And thank you for offering that. So just, I want to open it now to any clinicians. Final word to Dr. Graziani. I see Dr. Herson, Edery Herson is there. And I don't know if Dr. Karanowski is still there, but would love to hear final word from clinicians and how they see practice, research to practice, and Bauchi to Montreal.
Sorry, just running out with the mute button. But I'll say that it's amazing how different parts of the world have similar issues, and the lessons to be learned. It's quite impressive. I think after you met with my team, and I spoke with them as well. And so the question is how do you incorporate some of that here? Some of the challenge, I'm sure, is different. Time is though always a pressure for all of us, and what are priorities and how do we do that? And so I think the team was looking at how they could try to incorporate some of your work in what we do here. And I'm curious to hear from the team. I don't work with the team much myself, but we're trying to see how we can support them in their activities to try to make their offer of service as robust as possible for the people that we do.
Yeah, thanks, Mark. One of the things we've discussed with Perry and with Yvonne is possibly, to do some work with the adolescents they come across in the outreach, because very few of them end up coming to the service. So to do some fuzzy cognitive mapping with them. So I don't know if Michaela's around. Michaela and Yvonne met with them, and I think that the next stage is going to be to try doing some of this mapping with them to sort of see, what are the things that stop you coming? What are the hurdles for that stop you actually attending the clinic? So to kind of understand those, so that it might help them to to change the way things are, so that it makes it easier for them, because we don't know at the moment what are the hurdles for them, but they can tell us.
Wonderful. Dr. Dove, you had your hand up before?
Yes, no, I think Mark's points were all very pertinent. I wanted to thank Anne for presenting this very interesting work, and having worked a lot with adolescents. I worked for 10 years at the adolescent clinic at the Montreal Children's Hospital. There are definite similarities in the sort of reactions that I heard about in Bauchi State and here. I remember, girls coming in with very painful periods and suggesting that they be prescribed the oral contraceptive pill, and the parents asking, well, can you prescribe a pill that'll help with their periods, but it's not strong enough to be birth control because we don't want her to be on contraceptive pills. And that whole, I was very amused by your story, Anne, of like how some of the parents groups had a hard time focusing on what do adolescents need, and were more like, what's the problem with adolescents? So yes, a lot of things are transferable, and I think Mark addressed very well already the connections with research at the Herzl Adolescent Clinic.
Dr. Graziani, I know that you're just going into clinic, so this might not be a great time, but if you had any final reflections, we'd love to hear them.
Oh, I'm still here. I thought it was super interesting to hear about this project, and to also hear what's going on around the island itself, because we also differ a lot in our practices. And I'll definitely keep in mind that the ones that we see are not every there are still people what we're missing. So we have to find a way to, reach these people who are not coming. So hopefully we can maybe work on that and extend our services to the people we're missing.
Thank you. So thank you, Dr. Cockcroft, again for this amazing presentation. I think that we initially had in mind research that would drive clinical practice, but in fact, you're creating research that drives research practice as well, which is really fun. And then we definitely see the relationship between what is happening globally to what can happen locally. And we would just love to see much more of that happening. So blessings on everybody today as you begin your weekend, maybe not just yet, but thank you so much for showing up today and being here for our PBRN seminar. Thank you for your support, Anya, and taking good care of us today, and really appreciate it. It was a great idea, Alexandra. Thank you. Goodbye, everybody.
Thank you,
Bye.
Bye all.
Bye. Bye.
Bye. Bye. And
Bye. Thank you, everybody.
okay. Bye.
Bye. Okay.
Bye. Bye.
Bye. Okay, so thank you again, Anya. I think we can stop recording and
Yep.